So I want to talk to you about how we're going to differentiate a retina problem from an optic nerve problem, but in particular, one particular entity, which is an acute and usually idiopathic, although there are some causes, big blind spot syndrome. So the most common cause of an acute big blind spot is idiopathic. And the name of this thing is acute idiopathic blind spot enlargement syndrome. And so when we're looking at the optic nerve, of course, has no photoreceptors. And so when you have a blind spot that's bigger, it's because the peripapillary retina is bigger. And so normally, the thing that causes that is papilledema, or it can be peripapillary atrophy. So the first thing you need to do when you have a big blind spot is look at the nerve itself and see if you see the peripapillary atrophy or the papilledema. So if there's no retinal finding, that's going to be very deceiving, because normally when we have a big blind spot, we have papilledema or peripapillary atrophy. It's so obvious what the cause of the big blind spot is. However, when there's no retinal finding, that actually probably means it's retinal. And the reason is the arrangement of the nerve fiber layer is arcuate and respects the horizontal meridian, or it's papillomacular bundle and causes central or secocentral scotoma. So it's hard to generate an enlarged blind spot with nerve fiber layer. When you have enlargement of the blind spot, it usually means peripapillary retina is the problem. And so these patients have a very characteristic presentation. They're usually young and healthy patients. They're often female, but it can be male. They present with acute enlargement of their blind spot. It can be unilateral or bilateral, but it's usually unilateral. They might have photopsias, which is the key and differentiating feature suggesting that it's retinal versus optic nerve. The photopsia usually is described as a flashing light or a little flash bulb effect, like an after image, and it can be moving in their field inside the scotoma, so it's a swirling, flashing light inside of that field, and that's because it's retinal photoreceptors that are causing that. It's different than the after image of palinopsia, which is a bilateral simultaneous phenomenon that requires a stimulus. So this is a unilateral photopsia, and they often use that word flash bulb. It's like I looked at a camera flash bulb that caused it. And that's because it's stimulation coming from the retinal photoreceptors. And we're going to do two things on these people. OCT, but you have to do the OCT of the peripapillary retina, and a multifocal ERG, which is going to show depression in the area of the blind spot. The OCT is to look, because it's occult, so what we're looking for is the layers of the retina, and we're going to get hyperreflectivity. That hyperreflectivity can be above or below the middle part of the macula. So it's involving the inner nuclear layer or the photoreceptors. So it's the outer retina versus the inner retina or the middle retina. So in acute zonal occult outer retinopathy, it's occult because we can't see anything, and what we're trying to figure out is it inner or outer retina that has the hyperreflectivity. Over time, the hyperreflectivity will give way to optic atrophy or photoreceptor atrophy on the outer retina, or inner nuclear layer atrophy. That's going to be a late finding. In the outer atrophy, it's going to be the ISOS junction at the level of the ellipsoid. So OCT in the acute setting shows hyperreflectivity, in the chronic setting, atrophy. The key and differentiating feature: acute, unilateral, big blind spot, young, female, photopsia, flashing light, no RAPD, disc looks normal. Big blind spot on the field, no ophthalmoscopic correlate, OCT and MERG are diagnostic.